Hello, everybody. This Wednesday, we're going to be looking at working with an ACP, and I figured I would just provide a two-part lecture. One, just giving an overview of some of the directives, and two, just going over some medical math that we could talk about. So I'm just going to keep this very high level, very brief. Obviously, there's no expectation that you really retain any of this stuff. I just want you to be aware of some of the directives that ACPs have, and more importantly, from my perspective, I think it's really dangerous, which is the most important thing to address here. It's really dangerous to compartmentalize our profession and say, I have a PCB scope, this person has an ACP scope, they can worry about that. We are still a team, and cognitive load and systematic error still are a risk for me, the ACP, as well. And one of those systematic errors is compartmentalization, the idea that a PCP kind of works in a silo. So my idea here is not only to provide a high-level overview, but kind of emphasize some of the potential areas for variance or error that an ACP could run into. And although there's a whole separate conversation about finding your voice and speaking up when you might not know something, I really encourage you to ask questions. And if you ever think that one of these little points jumps into your mind in the middle of a call, I know, speaking as an ACP, I would absolutely appreciate knowing that you voiced that concern and we avoided an error, then find out that I committed an error and we committed an error and you were uncomfortable and didn't say anything. So first and foremost, let's look at cardiac ischemia. The big thing here is if your patient is cardiac contraindicated for nitroglycerin, then you're done. You just move on with aspirin and you move on. However, as an ACP, I may be able to give morphine, okay, basically in place of nitroglycerin or after the third nitroglycerin. So if we give 3 nitroglycerins, we can then give morphine, okay. So you may see morphine included in a cardiac ischemia call. The big thing to take away here is that while morphine is given for pain, it is given 2 to 10 milligram range for adults. However, it's a fixed dose for cardiac ischemia, and it's very likely an ACP who's likely giving morphine quite routinely for analgesia might lean to this, I'm going to give this person 5 milligrams or something. However, in cardiac ischemia, it's 2 milligrams every 5 minutes, okay? Next, let's look at cardioversion. Okay, so we can cardiovert with a drug first. We can try adenosine or lidocaine, depending on if the rhythm is narrow or wide, and they have different beats per minute criteria. However, if medications aren't working, we will do a cardioversion electrically. Okay, so that's like with the cardiac monitor, basically just defibrillating somebody while they're alive. At any point, narrow or wide, using electricity is a patch point, and drugs for wide are a patch point. If you think back to the baseball hitting somebody in the chest, R-on-T phenomenon thing, essentially we could do that to somebody with cardioversion. So it's really important that we do this thing called sync. Sounds complicated, but it's not. There is a button on the monitor. It'll be over here on our little squares on our Zoll, okay? And it says sync. And you click it, and then these little dots appear, and we want to make sure that these dots are lined up with our waves. Okay, and now we're R on R, not R on T. Okay. The next key thing to remind your ACP, which I didn't write down here, and there you go, I see it, I'm liable to forget things. When we defibrillate, we need to just press the shock button, but when we cardiovert, we need to press and hold the shock button. Okay, and that's how we actually get the monitor to activate this sync feature. Another thing you might notice is that you're going to defibrillate somebody while they're alive, and sedation is not a standing order. It's pretty routine in our culture that your ACP will patch for the cardioversion and then just ask about sedation anyways, and make it an order to give some drugs. Okay. Next is pacing, which is kind of the inverse. We're going to use the cardiac monitor for when the heart rate is too slow. The ACP may try a drug called atropine first. If that doesn't work, we're going to do pacing, and the pads will typically put on AP. And there's 2 things we need to think of here, okay? There's 2 kind of topics we learn. Getting a rhythm back on the cardiac monitor is called electrical capture, and essentially that's just cute. Okay, but there's no guarantee that that does anything. We need to make sure that when we're getting electrical capture, we're checking a pulse and also getting mechanical capture. Okay, so the big thing that I want you to remember here, if you're pacing, we need to check a pulse. Okay, this electricity is very little, so we can just take a pulse. We're not going to get shocked. Okay, we'll be all right to check a pulse on these patients. If there's no mechanical capture or very weak mechanical capture or very low systolic blood pressure, we may have a pump problem. Okay, the pump might be sad. And in that case, we may use the only vasopressor we have available to ourselves on the ambulance, which is dopamine. Something to think about here is that when we get into procedural sedation, we really like fentanyl compared to morphine, okay, when we're thinking about any concerns with blood pressure, okay. Fentanyl, less vasoactive, less effects on blood pressure. However, because of that lower effect on blood pressure, that's lovely because in a trauma, there's no blood pressure consideration. But if we're going to give fentanyl for procedural sedation, which we can do for pacing, okay, not a standard order for cardioversions, but for pacing, it is a standing order. However, the blood pressure must be normotensive. Intubation, I think, really just the big thing here is to know that we probably don't need to do it. There's high-grade evidence that intubation attempts are comparable to iGels in actual patient survival, and there's really high-grade evidence that missing an intubation is very detrimental for your patient, okay? Missing an intubation typically involves, an upwards of a minute of poor ventilation, and that is not going to be good for your patient at all. So really encourage your ACP to try to limit their attempts to 30 seconds, okay? Maybe make some comments about the SpO2, the end tidal, those kind of comments. Your end tidal will be 0 during the intubation attempt, as there will be no ventilations going on, but be really cautious of that time. They do have a maximum of 2 attempts, and if there's something I didn't write on here that's really important, it's the sniffing position, okay? If you feel like somebody's preached this to you about using the BVM, it's probably because it's been preached to them a ton about getting a successful intubation and getting a nice axes. Okay. The key things here I'm going to need you to do is pass me things, potentially do some burp, okay, or pull the bougie out of the tube. Okay. So this is a bougie. You can see that it has an endotracheal tube on it. Not always going to have the endotracheal tube on it. Some people may put just the bougie in, all the way up to this entire thing. And once they get the bougie through the cords, they may have you take the tube and slide it over. Okay. I personally like to do this, so you'll see this in lab. Once I get the bougie through the cords, okay, it's like a guide wire. So I'll slide this really easy, really thin, malleable bougie into the cords, and then we'll put the tube over top. We'll pass the tube along the bougie and into the cords, and then we'll remove the bougie. Okay. Other paramedics may prefer to use a stylet, which is more rigid and is just a way of giving the tube some shape. So instead of the tube kind of hitting something and flopping, the tube will stay straight. Some people like to add a bit of a curve to their tube. Okay. These are all personal preference. Personally, I'm not a stylet guy. We also may see a videoscope. Okay, so it still functions as a regular laryngoscope. I could just view directly in here. However, the camera will display what is down here. Okay. This is burp. It's this idea of doing backward, upward, rightward pressure. Okay, backward, upward, rightward pressure, and it's probably best that I reach down and do this, and then have you take the pressure with your hand. The idea here is, say I have this view, not great. I pull the tongue up and I pull the jaw up, and it's still not great. But then I reach over and I push. I reach over and I push backward, upward, rightward pressure. I may be able to actually bring this part down as opposed to this part of the jaw up, and I might get a better view there. We could push this part of the airway down more, and that may fix the alignment problem. Play with these tomorrow. Next thing is chest needles. Okay, the things for chest needles is we have 2 sites. Okay, you will often see a lot of resources online talk about 5th space. However, we use 4th space. Oh, not a great picture when I zoom in like this. So 4th anterior axillary line is essentially where you would put V5. And the alternate site, or the old site, this was the first and only site for a long time, and that's going to be mid-clavicular second space. Okay, you just take a needle and you puncture it through here. The risk here is that your needle could go too far and hit the lung. Okay, however, the lung is most likely deflated. So that's probably not an issue because the lung is probably deflated, and we're trying to puncture a hole in here. So all of this air that's pushing this lung in, we puncture a hole and this air rushes out. You literally will hear a needle go psss if it's really well placed and the pressure is actually accumulated. And then when ventilations come in, that should take this lung and reinflate it. Okay. These chest needles are likely to clog and whatnot, so they're not a great solution. The definitive care here is to put an actual chest tube in and attach it to suction. But that is a skill that the hospital will do. The thing I want you to know is that what the ACP should be doing is taking a 10 milliliter syringe and putting some saline in it, not all the way. If it's full all the way, it doesn't work as well. We just want to put a little bit of saline in. And then when you pass the needle through, as soon as you get through this space, as soon as you get through this last layer of skin, the mediastinum, or the visceral and parietal pleura, and you puncture in here, you're going to get air from this space rush up the needle, which is super cool because it will cause these bubbles inside of their fluid. So try to remind the ACP to attach to their chest needle a syringe with some saline in it. The next thing I want to talk about here is hyperkalemia. Remember, it's that really disorganized, potentially a sine wave. If it's not so severe, it might just be peaked T's. Okay, not your problem to figure that out. But if you get told that you're on a hyperkalemia call, the big thing is that we are going to be giving calcium gluconate over 3 minutes, which takes a while and ties up my hands. Any other options? Instead of giving it over 3 minutes, we could do an infusion in a 50 ml bag. When do you do that? PCPs? You can do that for TXA. Okay, same kind of idea. Just put the calcium gluconate into the 50 ml bag and run it kind of slowly. However, the other, not an alternative, but the other treatment simultaneously, okay, is to give salbutamol. Okay, and we're going to give 1,600 micrograms. So that's how many puffs? 16 puffs. And the dosing interval is 2 times immediately, which means really we're going to give 32 puffs. Okay, the idea of how it's even a second dose is that you look back at the monitor and you see if you have somehow miraculously, I don't know what that line was, sorry, somehow miraculously caused that T wave to flatten out a bit. Very unlikely, so I imagine it's pretty routine. Anytime I've done this 2 or 3 times now, I've given the full 32 with no real change. Okay, so this is just salbutamol, nothing special about it. Yeah, it bronchodilates, but it also pulls chloride into the conducting zone and exchanges potassium back out. Another thing I want to quickly talk about that you'll run into is this thing for analgesia dosing is called aliquots. Okay, where this is kind of an interesting thing, is that when we give morphine or fentanyl, the doses are literally just 2 to 10 milligrams or 25 to 75 micrograms. Okay, it's not per kilogram, and there's not really any guidelines based on how much somebody's had the drug or how much pain they're in. You just pick. Okay, for a lack of a better term, it's just a judgment call. They do have different dosing times, but you just pick. And the idea with an aliquot is that I could give you 2 milligrams of morphine, wait a few minutes, give you 2 milligrams of morphine, wait a few minutes, and give you 2 milligrams of morphine, and then say that I gave you 6 milligrams of morphine. And that would be over, 7 minutes or so. And then that's where I will count my 15 minutes. Another thing you will very commonly see is that I could give, say 25 micrograms of fentanyl. It doesn't even touch anything. I wait a few minutes, and then I just give you the rest. I give you the rest of the dose. Okay, and now I'm happy, and I call this my 5-minute increment. However, base hospital, I believe, would prefer that when we do aliquots, it's a consistent dose. So that would mean that this decided to do 2 at once. It really should have been a second 25 and then another 25, but this is not uncommon to see. Another thing we could just do is just give a dose that we want. So there's no problem with giving 50 if I choose 50 off the hop, and then I can just call it a day. But this is not an aliquot. This would just be a single dose. Moving on, in a VSA, same priorities here. Okay, good CPR, rapid trauma, rapid transport, and probably a pronunciation and considerations of penetrating trauma. However, the only other thing I might incorporate is that I may use a chest needle or an endotracheal tube. This, I'm not going to save anything here. Especially if you have a missed first attempt, not going to be good for prognosis. However, chest needles may deal with the reversible cause of tension pneumo. You used to require a patch for chest needles, but you do not anymore. Okay, our final topic that I'm going to quickly talk about is our medical VSA, and it's the same thing, okay? It's very different, but at the same time, based on everything we've talked about in lab, I want you to just realize that a good ACP medical arrest runs like a good PCP medical arrest. So don't let your ACP get tunnel visioned. Realize that the most important priorities, the most important priorities are 2-minute rhythm interpretations. So timing, okay, timing, good CPR, with switch every 2 min, okay, and a good airway, which you might say, well, then that's the spirit right there. But I-gels are great airways. Okay, if we're tubing, we're thinking hypoxic arrest. Okay, if we're not thinking hypoxic arrest, there's no need for it, or a failed I-gel, then there's not probably an indication for a tube. Okay, they're fancy, they're party tricks, they're old school. Okay. There is evidence to support, boom, I got a great intubation just like that. But there's stronger evidence to support, missed that first tube, and now everything just goes skydiving downwards in survivability if you miss this first tube. They may place an IV or an IO, and we're going to give 1 milligram in 10 milliliter epis. Okay, we're going to give just 1 milligram. Nice and simple. Every 4 minutes, an unlimited amount of times. Put yourself in the mindset of your dual sequential or vector change. However, a little bit different. If there's 2 shocks at any point in time in the call, then I'm going to start thinking lidocaine or amiodarone, depending where you work. But in Peterborough, we have lidocaine. And if the last rhythm interpretation was shockable, then I'm going to give lidocaine every 4 minutes, and I'm going to give 2 lidocaines. Okay? And I'm going to change my dose between the first and second. So a lot to remember, but if you're on a VSA and you see 2 shockable rhythms, you could say lidocaine. And if they give lidocaine once, and then they're getting ready to give a second one, you could say half as much. But also not your problem. Unlike, this conversation's come up a couple of times for us, in our trauma, fluid bolus, yep. But fluid bolus is less than valuable to transport. Okay. However, in our medical arrest, we very well may give a fluid bolus. And if we get a ROSC, we might give dopamine if they remain hypotensive. I would also count my new 1 liter ROSC fluid probably as a part of transitioning to this idea. Pediatric medical math is not as simple as 1 milligram per 10 milliliters. It's still relatively simple medical math calculations, but it's not unlikely that your medic ends up very hyper-focused if they have to do some pediatric medical math. So now more than ever, it's important that you're focusing on these things, okay? Especially good airway in our pediatric patients. All right, it's a little bit of a primer, okay? Talk about some more of this stuff, bring some questions. I will also record a part 2, and we'll cover some medical math conversations.